Guys, patients of chronic kidney disease are bound to deteriorate, and if the GFR goes to less than 15 ml per minute, in earlier times the term that we were using was end stage renal disease, but now we use the term renal failure. Now, because I know my patient will deteriorate, so I'll plan accordingly, and I'll plan a allogenic kidney transplantation in this patient. And as you can see, we do not remove the old kidneys, but the new kidney will be placed in the right iliac fossa. At this juncture, I would like to highlight that the main focus of this video would be to talk about the staging of chronic kidney disease and renal replacement therapy. I would also like to draw your attention to the fact that one of the very senior politicians in BJP-1 government, Sushma Swaraj ma'am, she was a diabetic. She underwent, she developed diabetic nephropathy, for which she had to undergo a allogenic kidney transplantation at AIIMS Hospital, New Delhi. But unfortunately, we lost her to a heart attack. That's myocardial infarction. And that's because, you see, diabetes causes increased CV mortality, and the topic of interest, chronic kidney disease, also contributes to increased CV mortality. So it's like a double insult that is happening. And that is why in a large number of questions that are asked on this topic, they would love to incorporate a histopathological slide into the integrated kind of questions of diabetic nephropathy. One of the classical histopathological findings that we see in a diabetic nephropathy is nodular glomerulosclerosis. The technical term for the same is Kimmelstein-Wilson changes that you would have read in pathology also. And you would also be remembering that diabetic nephropathy and diabetic retinopathy tend to coexist. In fact, in type 1 diabetes, it takes about 5 years for nephropathy and retinopathy to occur. And if it's type 2, it will take 15 to 20 years. So let's also revisit in the next 15 seconds findings of diabetic retinopathy, which would be one of the earliest one is neovascularization. They can be retinal hemorrhages. Then we can be having these venous beads, and more importantly, like they could be hard exudates. In fact, hard exudates are what we get in non-proliferative diabetic retinopathy as well, where there's a concomitant macular edema present, succinate rings present. So the message was just to sensitize you to the fact that diabetic kidney is usually asked, and histopathologically speaking, from the size of the specimen perspective, kidneys in diabetes are enlarged in size, and in these patients, their histopathological finding, the most common one that I'll be writing down subsequently is diffuse glomerulosclerosis, but the characteristic one is the slide that I showed to you, and that's the slide that's gonna come up immediately. That's the finding of nodular glomerulosclerosis, and now focus on the theory component for chronic kidney disease. We'll revisit some definitions once again. One of the definition that we will visit is that for chronic kidney disease, as I've explained to you, that if estimated GFR is less than 60 ml per minute, but while attempting questions, just be careful. Is he writing less than 3 months, or is it writing more than 3 months? Because if he will write here less than 3 months, then the answer will become acute kidney disease. Whereas if it's gonna be equal to or more than 3 months consecutively, this month, next month, consecutively, EGFR less than 60 ml per minute would be definition of the word, the topic of interest, that is chronic kidney disease. But as you can see in red, the marking here is to tell that if a person is having kidney failure word written, like we don't use the word end stage renal disease anymore, but just I'm writing it for the sake of completion to remind you that ESRD was the term that was being used, because this is when uremia manifestations used to occur, like uremic pericarditis, uremic encephalopathy, uremic melena. So because we were having these bad prognosis occurring, that is why we were planning to intervene with respect to when the GFR is much more than 15. So I'll subsequently be talking about like when do we plan and what are the grades of chronic kidney disease. The most common cause is obviously diabetic nephropathy, but he can ask you about other causes also, ranging from hypertension, autosomal dominant polycystic kidney disease, tubulointerstitial kidney diseases. And as far as GFR is concerned, guys, it varies with age and gender. In fact, from gender, I can say like women will be having less muscle mass, men will be having more muscle mass. So muscle mass also helps in deciding the value of GFR. And over and above this, serum creatinine, overall, I can say like what is the KFT that we do, or like GFR is evaluated on the basis of serum creatinine only. So serum creatinine varies with age and gender and then muscle mass. And when I said age, I just want to tell that GFR tends to decrease by at a rate of about like 1 ml per minute per year. From the third decade onwards, like the GFR 125 ml values obtained by approximately 30 years of age, and after that it decreases by like 1 ml every year. So usually by 70 years of age, the GFR would be like 70 ml per minute. I'll repeat that once again. GFR in our case tends to peak at around about the third decade. That would be like, 125 ml per minute. And then every year it decreases by 1 ml. So by the time a person is going to be like in his 70s, the GFR can be like 70 ml per minute. So whenever we are going to calculate the GFR of a patient, we have to take into consideration age, gender, muscle mass. And because a lot of patients are CKD are anyway having a catabolic process in their body, so their serum creatinine can even be lesser than normal. Like normal serum creatinine is 0.8 to 1.2. Do not be surprised that in chronic kidney disease patient, the creatinine value can be 0.7 and still we are saying kidney failure. Why it is less than normal is because of the significant muscle wasting that is present in these patients. So it's a rise, from 0.7, if it goes to even 1 in a patient of CKD, that indicates a deterioration. 1 is normal for you and me, but in a guy with a decreased renal reserve, value of 1 can be abnormal as well. In fact, most of the time, almost 50% of the kidney needs to be damaged before creatinine begins to rise. And then we have a couple of formulas which are used for calculation of glomerular filtration rate. And when I was a student your age, when I used to be asked like, how do you determine eGFR of a patient? Then we used to answer it as a Cockcroft-Gault formula. Now, Cockcroft-Gault formula was like 140 minus age into weight, and then the denominator in this case used to be 72 into serum creatinine. At that time, there were no online calculators, so we had to do a physical job of actually calculating the estimated glomerular filtration rate, and whatever mathematical value that used to come, suppose it came as X, whatever be the mathematical value, then we had to multiply this. We had to multiply this by 0.85. The multiplication factor of 0.85 was present in case the gender of the patient was female. Like suppose the value of X was turning out to be 100 and the patient was a female, then we had to multiply by 0.85 and the final value that we used to obtain was 85 ml per minute. But then as I explained to you that apart from age and weight, even gender, age, weight and gender obviously play a role, but then even race plays a role. So therefore, then the upgraded version was MDRD, that is modification of disease in renal disease formula. And nowadays, if we ask you what is the latest method for calculation of GFR, then online calculators available. Your answer would be given as CKD, EPI, cystatin C equation. This would be answered as the best method for calculation of glomerular filtration rate. At this moment, like the query that I get from a lot of people is that in physiology, we have studied about inulin clearance. So see, inulin clearance is okay from a physiology domain, but in real practice, it is not inulin clearance. The best method for calculation of estimated glomerular filtration rate is an online calculator. The name of that you'll have to select is CKD, EPI, cystatin C formula. And cystatin C is a product which is superior to serum creatinine to evaluate the damage to the kidney. In fact, for cystatin C, I mentioned even in the acute kidney injury video that this is freely filtered across the glomerulus. It is not reabsorbed. So it's like an ideal product, unlike serum creatinine, which is dependent on multiple factors. Cystatin C has lesser number of variables, and that is why it is being used while evaluation of patients' estimated glomerular filtration rate. And then he can ask you about Schwartz formula for GFR calculation in children. In this case, the important aspect to be remembered is that in children, we do not take into consideration the weight. It is the height of the individual that is to be considered. That is kappa into height, and the denominator would be whatever is the serum creatinine value. And as far as this kappa is concerned, it's like a value of about 0.41. So let's also attempt a question that came in the exam where he said like it's a 5-year-old kid, 16 kg weight, height of 100 centimeter, and serum creatinine was 1. So if I just do the same activity, kappa into height of an individual, that is 100, the denominator is 1, and the kappa value is what I've already told you is 0.41. So if you do a bit of mathematics here, the answer can be worked out. That is a GFR of 40 ml per minute. The important point or learning point here is that estimated glomerular filtration rate in children does not incorporate weight, but it incorporates height. And then the best method for calculation of eGFR is CKD EPI cystatin C equation. Now, what is that equation? Well, it's a complex mathematical one. So I don't think so that he's going to give you a mathematical formula like this. He has never done that in decades altogether of my teaching. So, but I just wanted to bring to your attention that, why I was saying the word online calculator, that is because this is a complex mathematical equation. Even if you have a calculator, the square root and under roots to be calculated is a bit of a challenge. And mostly we doctors have a bit of, I would say, limited knowledge of mathematics. Now we'll talk about grades of CKD, and this is one of the most important slide. In fact, in a recent NEET PG, the question simply was G3A. In FMJ exam, he mentioned as G3B. It's simple. He's just asking that values. So glomerular filtration rate for G1 would be at a value of more than 90 ml per minute. That would be 1.73 meter square of body surface area. Anyway, the GFR is calculated on the basis of body surface area. So the value to be remembered in this case is more than 90. And when I write this value, it is like the query is that, sir, you said CKD is less than 60, then suddenly where this 90 is coming from? So see, I want to pick up the disease early, no? I mean, why should I wait for the eGFR to become less than 60 and then say, I mean, value more than 90? Going up to 125, that is like he says normal, because the GFR is bound to decrease with age of an individual as well. But once the threshold of 90 is being created, that is what I was saying, that if I don't want to wait up to value to go to less than 60, I want to pick it earlier. So that is why G2 is to be remembered as value between 60 to 89, downgrade by about 30 points. Now the subsequent downgrade that you will do will be of 15 points, that is a GFR between 45 to 59 ml per minute. You see, if you think that you'll be able to remember this on your own, you won't be. So just take out a paper, pencil and a sticky on pad and try to write it down with me, because otherwise it becomes a little over too much to remember. And you can very well understand why did they ask about G3A and G3B, because here the downgrade that is happening is not 30 points. It was 90 to 60 is a downgrade of 30 points. Then we are downgrading from 60 to 30 again by 30 points, but then this is in multiples of 15 and 15 respectively from the mathematical domain. And now we are going to reach G4. This is a very critical stage, because this is when we say severe decrease of glomerular filtration rate. And in fact, here only I would like to mention that decision making for renal replacement therapy, that is either we are going to go ahead with the transplantation or we are going to go ahead with hemodialysis, that decision making process would be made with respect to the G4. I mean, this is like that final barrier beyond which there is only a progressive deterioration to hell, I can say, because if the GFR is less than 15, that's where uremia manifestations can occur. This is when earlier the technical term used was end-stage renal disease, and that used to cause a lot of depression in the patient mind and patient's relatives also. So I mean, that's why like we stopped saying the word end stage, because it creates a very negative image, and the word used is renal failure. So one, you need to remember the mathematical domain, and then also the word mild versus severe versus the term renal failure. I'll highlight this once again. RRT is renal replacement therapy that needs to be done in a patient, and as far as severe CKD is concerned, it is a value of less than 30, that is 15 to 29. If it's mild, it's in a range of 60 to 89. So a bit of numbering game has to be remembered. Let me just focus on what are the numbers that I expect you to remember right now, right here. One is the cutoff of 90, where everything is like cool. But anything beyond this is a troublemaker. So one, I said less than 60 for more than 3 months is CKD, less than 3 months is acute kidney disease. Then downgrade by 15, so G3 and G3B till you reach G4. That's the threshold for RRT. And anything less than this is where bad news would happen. This is where you can get hyperkalemia, hyperphosphatemia, metabolic acidosis, and because there would be a substantial amount of like electrolyte imbalances as well at G5. So that is why if the chances of mortality in a person would be increased. Now, along with calculation of grades of CKD, they also ask you with respect to protein loss in the urine. And in this case, we don't need to go for a timed specimen. Like we don't need to collect the urine for 24 hours. The patient has come right now. We are going to take a spot sample. And in the spot sample, the test that you will write will be that in the numerator, you will be asking the lab technician to check for the magnitude or amount of urine albumin. And in the denominator, we will be checking urinary creatinine. Mark my words there, this creatinine that I'm talking about is not of the blood value but in the urine. What I'm teaching at the moment is simply called as urine albumin creatinine ratio, and that tells us that the kidney is damaged. It's a part of the structural criteria. Now, as far as A1 is concerned, that would be a value of less than 30 milligram per gram of urinary creatinine. Then is 30 to 300 or more than 300. So you need to remember A1, A2 and A3. And in some MCQs, he'll play by a bit of mathematics. So I want you to pay attention to the fact that when the denominator is changing to millimoles, you need to decrease 110. Like you can see earlier, I was saying a value of 30. Now you can see the value has changed to 3 milligram. Numerator is the same, but because there's a change in the denominator, you just need to remove this 0 and then it will become 3 milligram per millimole. Similarly, if you go to A2, you just need to remove 110 here, and you can see it will become 3230. And similarly here it will become, instead of 300, it will become 30. So don't be surprised if you get questions in which the values are given as like this, because when I'm telling you values less than 30, and then you see in this here also the values turning out to be less than 30, it looks like everything is fine, but it is being turning out to be A2 because the denominator is changing. So most of the time when it comes to urinary albumin creatinine ratio, the examiner may deliberately in the denominator not mention the word gram, but he might mention the word millimoles of urinary creatinine. In the numerator, it is like the standard albumin component only, but in the denominator, the urinary creatinine is being taken instead of being grams as millimoles. So why this is all is being told to you is because when a patient would come to me, like initially when he came to me, maybe a couple of years back, there's a possibility that this patient was in G3A, and along with G3A, his albumin status was A1. So we write on the case file, like we write G3A and we write A1 just to signify that in this person, there is a progressive deterioration that is happening. And today when my patient has come to me, then what I'm noticing is that he has deteriorated in a sense that now this patient has gone into G4A2. So I'll be telling you, sir, it is time for like intervention. This diabetic patient, when he came to me initially, I said like you need to take your medicines regularly. I'll teach you medicines that to be prescribed to these patients to reduce the progression of diabetic nephropathy. And one I can say is like AC inhibitors that should be given, SGLT2 inhibitors should be given, Fenranon should be given so that this progressive deterioration can be prevented. Now patient listened to me. He did pay for consultation also, but did not turn up subsequently. So in those cases, there's like a progressive deterioration that is happening. So this is a simple chart which helps us understand the progressive deterioration and a loss of renal reserve. And here you can see G1, G2 is not like Gravida 1, Gravida 2. It is the grades of deterioration as far as GFR is concerned. And along with that, A1, A2, A3 is what I explained is the albuminuria component. And do take care of whether the denominator is in grams or whether the denominator is in millimoles, because the values are bound to change. With this information in mind, we'll now focus on like what are causes apart from diabetes. Then it could be glomerulonephritis. The glomerulonephritis that I'm talking about at the moment would be called as CGN, that is chronic glomerulonephritis. That is like the sequelae of all the types of glomerulonephritis. Then is hypertension and ischemic heart disease, because most patients of ischemic heart disease can be having triple vessel disease, and I advise the patient for coronary artery bypass grafting. Now patient said yes, but he never got it done. He kept on thinking about it, and meanwhile the heart was damaged. So you know that especially in India, ischemic heart disease can cause ischemic cardiomyopathy, and therefore the cardiac output will drop. The blood supply to kidney will also gradually reduce, and these patients can then progress into cardiorenal syndrome. What I mean by cardiorenal is initially the heart is damaged and then subsequently kidneys also get damaged. Autosomal dominant polycystic kidney disease and tubulointerstitial kidney diseases both have been discussed separately with respect to ciliopathy. So I would request you to look at them also. But at the moment, I want to say that almost like 90% of cases of chronic kidney disease are from these top 5 causes that I mentioned. I repeat my statement, 90% of cases of chronic kidney disease are from these top 5 causes that I've enumerated, the mnemonic for which are gonna be DG hat. And let's just quickly recap that. One is gonna be diabetes, then is gonna be glomerulonephritis of the chronic variety, then is hypertension and associated complications, then is autosomal dominant polycystic kidney disease and tubulointerstitial kidney disease, which itself is of 2 variety. As far as enlarged kidneys are concerned, polycystic kidney, everybody knows, now never a problem. Amyloidosis, you know from pathology. But 2 additional points which I want you to remember for bilaterally enlarged kidneys would be diabetes mellitus, and then would be HIV-associated nephropathy. In fact, the histopathological finding that you get in HIV-associated nephropathy is by the name of focal segmental glomerulosclerosis. Now, more about focal segmental glomerulosclerosis is given in the nephrotic syndrome video, but at the moment, I just want to bring to your attention HIV-associated nephropathy contributes to development of nephrotic range manifestations, and at the same time, it is also going to contribute to like bilaterally enlarged kidneys. Then our focus would be on the clinical profile, why patients would come to us. So because CKD is all about a catabolic process in the body. So there is bound to be weight loss, there is bound to be like a reduced appetite, and there would be nausea, there would be hiccups. The reason for this hiccups can be explained by the fact that urea is a toxin, and when it accumulates in the body, it's going to contribute to irritation of the diaphragm. And the irritation of the diaphragm can explain the development of hiccups in these patients. because the RAS system will be activated. GFR is less, no, so RAS will be activated. So there would be like more aldosterone in the body. More aldosterone will draw more water, and that explains why there can be an anasarca, why there can be like a pedal edema. In fact, in some of these cases, the volume expansion that is caused by aldosterone can be so substantial that it can even cause breathing difficulty in these patients, that is pulmonary edema. Then because the toxins are accumulating, they can be like muscle cramps, they can be twitching and irritability. And one more reason I can explain for the twitching component is that in these patients, vitamin D production, because kidney produces vitamin D also, no? So if vitamin D will become less, then calcium values will also become less, and that less calcium can explain the increased neuromuscular excitability occurring in these patients. There would be itching, there can be skin pigmentation, the RAS activation can explain the hypertension, which is very stubborn and difficult to manage. So drugs for control of hypertension will be discussed subsequently. And then while evaluating this patient, I will be evaluating for auditory and visual problems. That is to just sensitize you to the fact that there can be a defect of type 4 collagen and a COL4A gene. You are aware that in Alport syndrome, again, we can be having a end-stage renal disease or renal failure developing in a patient. Alport syndrome is a condition where we get anterior lenticonus, there is a sensory neural deafness, and that is why we were trying to evaluate this patient for any ocular complaints and simultaneously for the eye issues as well. And ultimately, renal failure will ensue and there would be positive family history given in this patient. For integumentary skin disease, I would like to remind you regarding Fabry's disease, where we have angiokeratomas. And Fabry's disease can also contribute to damage to kidneys. Then can be heavy metal exposure and drinking water supply. So these are like just an overview to tell you like the person is deteriorating. There is accumulation of toxins in the body. And at this moment, I've not written anything very strongly suggestive of uremia. But if the GFR goes to less than 15, that's when these patients will be having uremic pericarditis, uremic melena, and very substantial electrolyte imbalances, which will not respond to medical therapy, and we will have to plan dialysis. So because we know it's a progressive downhill ride, we would like to intervene. Now, what are the interventions? What is medical management of CKD? I'm talking about medical management of CKD. Then we'll talk about the dialysis component and renal replacement therapy. So the mnemonic to be remembered for this is A, B, C, D, E, K. And A is for keeping HbA1c value less than 7%. That is good sugar control. I've already explained to you in the diabetes section, stop metformin if eGFR of the patient is less than 30 ml per minute. And in all patients of chronic kidney disease, drugs should be started diabetic nephropathy patients to slow down the progression of diabetic nephropathy. The first weapon that we have to slow down the progression is low dose ACE inhibitor. So you will notice a lot of diabetic patients on like captopril, ramipril. They're not having hypertension, but still they're on these medicines because ACE inhibitors will dilate the efferent arteriole. It will reduce the intraglomerular pressure, and that will reduce the pressure on the basement membrane. And the magnitude of albuminuria will also reduce. So in ACE inhibitors, like they are the first line approach. But over and above this, these patients should also be started on SGLT2 inhibitors. This has been again discussed from the perspective of diabetes, that one of the molecule we use is like gliflozin is okay, but which gliflozin can be used in eGFR as low as up to 20, then it is empagliflozin that can be used. Because these patients would be having edema because of the volume expansion, we will have to give aldosterone antagonist to these patients, and the molecule that we'll be using is finerenone. We can be using spironolactone also, but at the moment my focus was to talk about drugs that are gonna slow down the progression of chronic kidney disease. So that's gonna be like ACE inhibitors, SGLT2 inhibitors, and finerenone. Now, what I say next is from the pharmacological perspective, like he will say that the kidney of this patient is already damaged. So which drugs in diabetes can be metabolized by the liver? So I would like to mention a name of couple of drugs which they want to listen, because these drugs are metabolized by the liver. That is, one is DPP4 inhibitor, that is linagliptin. And the second one is what I used to answer when my consultant used to ask me that a person of diabetes is having kidney involvement. So which anti-diabetic drug would you like to give that is metabolized by the liver so that you can get a glycemic control? So these are anti-diabetic drugs which are metabolized by the liver. In contrast, metformin is gonna be like, big time contraindication. There have been like, instances when, reputed doctors have continued giving metformin to people who are having low GFR that can result in development of lactic acidosis. So anti-diabetic drugs, which are basically metabolized by the liver, is what I've highlighted at the moment. There are two of them that begin with alphabet G, that is linagliptin, and second is glipizide. In ideal circumstances, what I would like to do is, though patients may be resistant for this, is especially if like in type 2 diabetes, I've said if HbA1c is like more than 10%, it could be 11, it could be 12, then I'll tell the patient that, sir, I would like to put you on insulin. Now, where is insulin metabolized from? Then insulin is also metabolized by the kidney. So they put this in pharmacology. They said in a patient who's having damage to the kidney, when you prescribe insulin in place of anti-diabetic drugs, what should be the dose of insulin that should be given? Would you like to give the standard dose on the basis of body weight? Would you like to give a higher than normal dose? Would you like to give less than what is the calculated dose? Your answer is like 80% of the calculated dose, because if I give a regular dose, that's not going to be metabolized by the kidney. If it's not going to be metabolized, it's bound to cause hypoglycemia. I repeat this fact again, guys. Insulin is metabolized by the kidney itself. Because the kidney is malfunctioning, if I give a standard dose of insulin, it will bound to cause hypoglycemia. So I will be giving lesser than the normal dose. Then alphabet B is for the mnemonic is A, B, C, D, E and K for the medical management. The K is for potassium. The B is for blood pressure because it's a high renin hypertension. So wherever possible, we should try to decrease the blood pressure using ACE inhibitors to less than 130 by 80 millimeters of mercury. What I mean by achievable is like, I don't want postural hypertension. If I'm going to be super aggressive in control of blood pressure, if he's like doing even 140 by 90, I'm okay. I want to go up to 130 by 80 or lesser, but if person starts having postural hypertension, I would not like to take a risk at the moment. I put a line in between to sensitize that if he just says the word which drugs will slow the progression, then linagliptin glipizide don't slow the progression. Slowing the progression is ACE inhibitor, SGLT2 inhibitor and Fintranon. This information that I put on the right hand side is a miscellaneous aspect, just to remind you that there are certain antidiabetic drugs which are metabolized by the liver. That is going to be like linagliptin and glipizide. Now, what happens if there is a hyperkalemia? Because CKD is bound to cause hyperkalemia. And can I give ACE inhibitors in hyperkalemia? No. So I will also discuss with you the strategy that we have to use. And at this moment, I also want to say that how do ACE inhibitors work? They dilate the efferent arteriole. If they dilate the efferent arteriole, the pressure gradient in the kidney will bound to fall. And that can result in a slight decrease in GFR up to as much as 30%. So when you give ACE inhibitors to your patient, you have to calculate eGFR before giving ACE inhibitor and after giving ACE inhibitor, because ACE inhibitor will dilate the efferent arteriole, and therefore if you dilate that efferent arteriole, then the pressure gradient is lost. You see, efferent arteriole is dilated, efferent is constricted. If you dilate the efferent arteriole, pressure gradient is gone. That is why in these patients, there can be like a substantial amount of deterioration. So with respect to GFR, so watch on the same has to be kept. And if the eGFR is falling more than 30% after starting of ACE inhibitor, then we need to discontinue it. So one indication for discontinuation is hyperkalemia. The second indication is a progressive decrease of eGFR more than 30%. I repeat my fact once again, ACE inhibitors are very good in diabetics, but if they cause a more than 30% decrease in eGFR on starting, or there is a concomitant hyperkalemia, put a full stop. Like if person is having hypertension with hyperkalemia, then first what I will treat is hyperkalemia. I will try to lower it by giving furosemide. I can also give potassium binding resins to these patients. The novel potassium binder that I can give to the patient is like Patiromer. So if I have a case of hypertension with hyperkalemia can contribute to cardiac issues. So I would like to try and decrease it immediately. And therefore, initially what I can do to lower the value. See, I'm not saying patient is having a value of 8. If I say life-threatening value of 8, then just calcium gluconate insulin drip. I'm talking about a long-standing hyperkalemia with a potassium value stubbornly at 6.5. So what I can do is to downgrade from 6.5 downwards. I can do Caliuria, I can give Patiromer, and if the potassium does not come down, then I will stop ACE inhibitors and introduce calcium channel blockers. Along with this, because there's bound to be edema present in these patients, there could be periorbital edema, anasarca, and pedal edema. So I need to give diuretics. And what is the diuretic that we'll be giving is most of the time thiazide diuretics, because you can see that furosemide on a long-term basis does not make sense. It's like a high ceiling diuretic, and in CKD we use thiazide. Now he will ask you which is the safe or the safest thiazide diuretic that you can be giving to your patient who's having CKD, then your answer would be given as metazolone. Metazolone is safer as compared to chlorthalidone. I mean, chlorthalidone is used at a value more than 30 ml, whereas metazolone can be used even in eGFR less than 30 ml per minute. If the eGFR is more than 30, then it is okay. Then we can be using even chlorthalidone in the patient. But if it is less than 30, then it is going to be answered by you as metazolone. And if the BP is not controlled in spite of like giving CCB and diuretics, then the next approach would be that we will give alpha-1 blocker to the patient, that is prazosin or tazocine. And this is a question that was asked in NEET PG. Here mentioned the fact, like I, for your comfort level, I had written the word end stage renal disease, because that's when like very severe hyperkalemia can be present, and they can be like very severe increase in renin and aldosterone values to be present. But like the technical term is obviously, as I've said multiple times, renal failure for, I mean, this was the word that was written in the question. In a patient with renal failure, which drug would be used if the blood pressure is not getting controlled by standard antihypertensive drugs? And he mentioned that the person was having pedal edema also. You see, calcium channel blockers can contribute to worsening of the ankle edema. So that means diuretics are being given and still the BP is not getting controlled, and CCB already is being given. So increasing the dose of CCB does not make sense, because if I increase the dose, it will cause ankle edema. So the new drug that will be added is prazosin. Pure clinical based question, I'll say this once again. The point to be understood is, I am having a patient of chronic kidney disease. He's having pedal edema, and his BP is not getting controlled by giving diuretics and calcium channel blockers. So what should I do? Should I increase the dose of diuretic? Should I increase the dose of CCB, or should I add a new drug? Adding CCB anyway does not make sense, because it is going to bound to worsen the ankle edema of that patient. And then thiazide diuretic, even if I increase, like it's not going to have a very significant, I mean, thiazides have a limited capability to decrease the blood pressure of a patient. So I need more firepower, and that more firepower will come by use of alpha-1 blocker. So at the moment, the learning point is, if he just says what is the antihypertensive of choice in a patient of CKD, nothing else is given, answer is ACE inhibitor or ARB. If he just says drug of choice for hypertension control in a patient of CKD, is answer is ACE inhibitor or ARB. But if he starts adding hyperkalemia in the question, that means the GFR is progressively falling, then what will you do first? First, you will try to lose potassium from the body. Even if then potassium is not getting lower down, and it is stubborn, and hypertension is also stubbornly present, so then I can stop ACE inhibitors and add CCB. Then I can add a diuretic like metazolone, and if it is still elevated, I can then add prazosin. So CCB, thiazide and prazosin is the algorithm for control of hypertension with hyperkalemia that I have mentioned. The basic point is, a potassium, if he gives you a potassium outrageously high values, no, suppose he himself mentions potassium value 7, 6.5. So these are like, dangerous values where I need to be very wary, because if the values become critically high, then they can be a possibility of cardiac arrest also. So, and this has been like the value not once, like multiple reports are showing like 6.5, 6.8, 7. So it keeps on fluctuating in this range. So I'll try to immediately try to lower the potassium and stop ACE inhibitor, and then give calcium channel blockers to this patient. I've talked about A and B. Next is C, cholesterol control. Cholesterol control means that we have to target LDL, and this target LDL should be kept at like less than 70. Normal LDL values in ordinary people, it can be less than 130, but in diabetic patients with the nephropathy component, it has to be kept as less than 70. And if a diabetic patient has already had a heart attack, like I'm writing atherosclerotic cardiovascular disease, what I mean by the word like atherosclerotic CVD is like he's already had a myocardial infarction, or he has already undergone a bypass grafting, or he has already undergone a PCI stenting. If anything of these are already occurred in the patient, and he says what is the target LDL in this extremely high risk patient, then the target LDL is not 70, then it should be given as like less than 55. So the objective of mine was just to bring to your attention or sensitize you to the fact that we have like, control of statins is important. Why is that control important? Is because there is a higher incidence of cardiovascular mortality in diabetic patients. So you have to keep the bad cholesterol under check. So A is HbA1c, means BP control, and C is cholesterol. And then we need to take care of vitamin D also, because vitamin D is synthesized by the kidney by the proximal converter tubules. Our proximal converter tubules contain an enzyme by the name 1-alpha hydroxylase, and this helps in synthesis of 125 dihydroxycholecalciferol. And because this enzyme is gonna be like lesser, is because kidney will be damaged, so the enzyme activity will also be lesser. So the synthesis of vitamin D3, that is 125 dihydroxycholecalciferol, will be less, and that is why in these patients hypocalcemia will be present, and that will cause release of PTH, so secondary hyperparathyroidism. The reason why hyperphosphatemia will occur is mainly because of inability to excrete phosphate, because GFR is low. So inability to excrete phosphate is the reason for like the hyperphosphatemia, and that is bad news because then this phosphate will chelate with calcium. Though calcium is low in the body of this patient, whatever is present, it will bind further with phosphate, and that can contribute to complications like tumoral calcinosis, where lumps can be present near the joints. These would be like globular calcifications in periarticular soft tissues around the joints. Lumps could be felt. Then can be calciphylaxis. The meaning of the word calciphylaxis would be calcium deposition of arterioles. Imagine calcification not in large arteries, that will anyway happen. Calcification in the arterioles can happen. Calcification in small blood vessels can happen, and that can result in a painful libido reticularis and even a development of like a horrible looking ulcer that you can see. So what is calciphylaxis? It is a calcific uremic arteriopathy. What I mean by uremic arteriopathy is that in these patients, there is phosphate chelating with calcium, and it is the arterioles that are damaged which can cause these festering wounds to develop in these patients with secondary infection. So phosphate is like a big time troublemaker. Guys, it's such a big troublemaker that it can cause calcification of even the iliac vessels, and iliac vessels, if they get calcified, then we cannot do kidney transplantation even if donor is available and matching is perfect match. Suppose somebody has a cousin brother who's ready to donate, matching is also happening, but if the person, the recipient, is having calcification of the iliac artery, then you cannot do vascular anastomosis. And that's why subsequently I'll talk about like Doppler to be done in a patient who's like a Doppler would be done both in the donor and the recipient, but then Doppler would help me pick up even in the recipient possible calcification of the iliac arteries, and that is why we worried about phosphate. So I'll teach you drugs that we are going to use for excretion of phosphate from the body, but at the moment the data stands like this. If he says what happens to serum calcium in a patient of CKD, it is low. What happens to phosphate in these patients? It is elevated, and because bone turnover is increased, so they can be high serum alkaline phosphatase. In CKD, we can have both a high bone turnover and low bone turnover. For high bone turnover, you will notice that there would be increase in the value of serum alkaline phosphatase. I'll tell you the reason for low bone turnover as well, but at this moment I'm trying to focus on the aspect of high bone turnover, where the report will say low calcium, more phosphate and serum alkaline phosphatase, and these two will chelate with each other and they'll get deposited in the tissues. They'll be deposited in the soft tissues around the joint, so we'll call it tumoral calcinosis. They can get deposited in the blood vessels of the skin, that can result in a festering ulcer as well, that is calciphylaxis, and they could be involvement of large vessels like iliac vessels also, that could result in these patients not being able to undergo kidney transplantation. PTH is like bad news. Excess of PTH will cause a bone destruction. That bone destruction is written in pathology as osteitis cystica fibrosa. There are cysts in the bone, and in those cysts bleeding will occur, and when the bleeding will occur, then the RBCs will break down to produce hemoglobin, which is brown in color. So therefore the term used as brown tumor. You are aware that brown tumor word is actually a misnomer. I mean, there is no tumor present here. It is just that because PTH is causing destruction of the bone, so there would be cysts, and inside this cyst, because bleeding can occur, and because this bleeding is like on a chronic basis, so that's why the term used is brown tumor. Plus, there can be radiological finding of subperiosteal reabsorption of phalanges, which I'll just show to you. If you focus on the X-ray on the right hand side, you can notice that there is the expansile lesion in the bone. There is even damage to the phalanges or subperiosteal reabsorption of phalanges that is occurring. So all these are findings that are seen with respect to a diabetic kidney or generally any cause of chronic kidney disease, because vitamin D production is lesser. I mean, overall from the hormone perspective, which hormone is less and which is more? So in CKD patients, it is vitamin D3 that is less and it is PTH that is more. From the perspective of hormone, it is vitamin D that is less and PTH that is more. And because vitamin D is less, therefore there is a hypocalcemia, as I explained. But calcium and phosphate, as the rule is in medicine, no, they always go opposite ways. So phosphate values will be given as elevated. I chose to write this point once again because this is a must-know fact. For hyperphosphatemia is a feature of both acute kidney injury, acute kidney disease, and would also be seen in patients of chronic kidney disease. Now, what are we going to do for management of this hyperphosphatemia, because it is so dangerous that it can contribute to development of tissues getting affected, blood vessels getting affected. So what we can use in this patient is a binder. The name of this binder to be remembered is Sevelamer. That is usually the question that will be asked to you, that Sevelamer is used for in CKD. For which purpose? Your answer is it is a phosphate binder. The second molecule that is available here is lanthanum carbonate. There's a second group of molecules also. I mean, these are the newer ones. Otherwise, we can use calcium acetate for these patients also. So medical management of hyperphosphatemia is the main focus. And along with this, the second aspect is PTH in the body is more. So we would like to inhibit PTH production. What I'm saying next is, because PTH is more, I want to give a calcium mimetic drug. This will look like calcium. So therefore, the PTH values will tend to normalize, because otherwise PTH will contribute to bone damage. The objective of mine is PTH normalization. I want to get it back towards normal. If higher is the PTH, more will be the bone destruction. So a calcium mimetic drug which will help in PTH normalization in patients of CKD should be answered as cinacalcet, and therefore the whole thing will revolve around the following aspects. One, he will ask you the derangements. What is less, what is more? Everything is less. Only thing more is phosphate only. I mean, two things that are more are beginning with P, that is PTH and phosphate. I'll highlight these 2 points once again. I mean, everything is less except for two things beginning with P, that is PTH and phosphate will be more. And what are you going to do for it? Then it is sevelamer, lanthanum, calcium acetate, and cinacalcet, which is a calcium mimetic drug. It will behave like calcium. The parathyroid gland will be fooled into thinking, okay, now PTH is available. So gradually the levels will go down. And if I don't decrease these PTH values, then the bone destruction, the osteoitis cystica fibrosa, and the progression of brown tumor will continue to occur. Let's look at electrolyte imbalances in chronic kidney disease. If he says what happens to sodium, the answer would be less. The reason for this can be explained by the fact that this condition of CKD has more of aldosterone. More aldosterone will cause more water in the body, and that water will cause a dilution. So the technical word is, because more water, so I'm saying hypervolemic, and there's a dilution component also happening. So hypervolemic, hyponatremia will be occurring. Potassium will be elevated because there is inability to excrete potassium, but he can mention hypokalemia also. But the reason for that hypokalemia would be excess use of diuretics for that stubble edema. So the learning point is hyperkalemia as well as hypokalemia both can occur in CKD. In acute kidney injury, we only have hyperkalemia. The learning point is, in acute kidney injury, we have only hyperkalemia. But in chronic kidney disease MCQs, there's a possibility that patient can have hyperkalemia also, patient can have hypokalemia also. What I mean is that if the patient is not being given a treatment, then potassium will be elevated. But when do we get a hypokalemia? Is on aggressive treatment. And the reason for this is we want to take care of that stubborn edema. So because we are trying to escalate the dose of diuretics, that is why the hypokalemia component can occur. Then phosphate in these patients would be elevated, calcium will be less, and there would be like chelation between the two, which can result in tumoral calcinosis, it can result in calciphylaxis, those peculiar terms he would like to hear. And from the hormone perspective, I said vitamin D is less and PTH is more. This is one of the most important aspects of that ABCD mnemonic I was saying, that is aspects related to vitamin D being low and the synthesis of vitamin D being less are the core aspects that he would like to listen. And now he would also like to talk about decreased bone turnover. The decreased bone turnover would be referred to as adynamic bone disease. You will notice that in some patients of CKD due to uremia, because uremia is a toxin environment, so osteoblast will not functioning normally. Adynamic bone disease in CKD basically means a low bone turnover. And the best rationale for this low bone turnover can be that uremia is having toxins accumulating in the body. So in the presence of toxins, osteoblast and osteoclast will not be able to do their activity. Blast जो होते हैं में B होता है, they're responsible for bone formation, and osteoclast are for bone destruction. But in these patients, due to uremia component, that is one issue. Second can be aggressive treatment of suppression of PTH. Like if we use too much of calcium acetate, we use suppression of PTH with cinacalcet, then they can be like the side effect of cinacalcet usage can be that if you suppress PTH, then the bone turnover will be reduced. So the message here is there are two reasons why we get adynamic bone disease. One is that the uremia component is damaging the environment of the bone and there is like a low bone turnover. Second is super aggressive treatment, because we assume that all cases are having a high bone turnover. That's okay, but then don't do over aggression of the high bone turnover, because then that's gonna cause a side effect of this aggressive treatment of yours. That's a low bone turnover, and final result is bones become brittle. I mean, why we are worried about this is like, the bones are brittle, so there can be a risk of fracture. So like if the bone turnover is more, like there was cysts developing in the bone, they were bleeding, and if the bone turnover is less, then they are brittle like a chalk and they can fracture. So pathological fractures are common in diabetics, and that is what I wanted to highlight. Now, the next part of the discussion revolves around erythropoietin deficiency, which is going to be produced from the kidney, and the kidney is affected. you see there are three hormones which are produced by the kidney. One of them is renin. Now, if renin is less, that means aldosterone values will also begin to drop in this patient. That can explain renal tubular acidosis type 4 that can occur. Then erythropoietin deficiency will explain the anemia. And over and above this, prior to this, we discussed vitamin D deficiency, which can contribute to hypocalcemia and hyperphosphatemia. Now, this was mainly from the physiology perspective, but the main aspect is if erythropoietin is deficient, then the synthesis of red blood cells would also be lesser, and therefore in patients of chronic kidney disease, RBC count is lesser as compared to normal. The hemoglobin will also be lesser. Now, one of the reasons for like anemia is low RBC count, but then there is fibrosis in the bone marrow also because of the PTH, which was causing that osteitis cystica fibrosa. Plus, it's a chronic disorder, so inflammatory state will contribute to the anemia component. Plus, there is increased risk of bleeding because uremia interferes with the clotting process, both the extrinsic and the intrinsic step. So, there are four reasons why we get anemia in patients of chronic kidney disease. But among these, if he asks you to select one and he says what is the main cause of anemia in patients of CKD, then the answer is erythropoietin deficiency. I said kidney is responsible for synthesis of three hormones. Deficiency of each one of them will cause specific manifestations. And now let's look at like what are we going to do for management of this anemia, which is multifactorial. The initial part is that we need to establish a target. The target hemoglobin that I want in patients with CKD would be in a range of about 10 to 10.5 grams at least. And for this, first we need to build up the stores. Erythropoietin stimulating agents will obviously be given, but then before this, we need to build up the stores. So initial treatment of this patient is intravenous iron so that we can build up the values of low ferritin. We have hypoferritinemia in these patients. So initially, like we get ferritin back to normal. Then we have to give these injectable molecules that is going to be erythropoietin stimulating agents. And these are like darbepoetin or eptoin. And the disadvantage is that they are having the requirement of injections to be given on monthly basis. More importantly, there is a side effect of these. They can also contribute to development of hypertension. So there was always a need for an oral drug and ease of availability. So now we have one that is FDA approved and is used in European Union and Japan, that is roxadustat. Well, what is this molecule? This is hypoxia inducible factor prolyl hydroxylase inhibitor. That prolyl hydroxylase is an enzyme that causes destruction of hypoxia inducible factor. The advantage of this molecule is it is oral available. So you need to remember a new drug that is HIF-PH stabilizer. What that means is that it inhibits the breakdown of hypoxia inducible factor and tends to increase the values of erythropoietin in the body. This is like, you can imagine like an endogenous erythropoietin, like you were giving exogenous, no? It's like an endogenous booster of erythropoietin production, which is happening from the kidneys. What is the primary mechanism of action of point number C that I mentioned for this discussion? As far as the hyperkalemia of CKD is concerned, then don't mix it with hyperkalemia that could be of acute onset and that is occurring with acute kidney injury. Here it's like a gradual rise of potassium. So what we can do is we can lose potassium by giving diuretics like thiazides. I've already told you in the thiazide that we can use metazolone, or we can be using even chlorthalidone. The newer potassium binding agents, which I've spoken about in my earlier video lectures and I'm talking about at this moment, are like patiromer. That is one of them. It's a potassium binding agent. It will reduce the binding. I mean, it will bind potassium in the gut only. So the absorption by the intestine is relatively lesser. The second one that he would like to hear is like sodium zirconate. So you will notice that in a large number of questions of CKD where he's wanna talk about the drug treatment, then he will talk about sevelamer and lanthanum for hyperphosphatemia and the novel potassium agents that I am speaking about at the moment for patients who are having hyperkalemia on a long-term basis. This is the old one. The third one that I'm writing is like an old one. It was available as enema also, like once a week enema can be given. The tablets are the same as well. That is sodium polystyrene sulfonate. Now the problem with the enema of sodium polystyrene sulfonate is it can result in development of even necrosis or damage to the colonic mucosa. So it is like the newer ones that you would usually like to hear about, that is patiromer and sodium zirconate. And the overall aspect is like how do you decrease potassium in patients with CKD? Then it is diuretics, that is thiazides, and along with that patiromer and sodium zirconate to bring down the potassium values. If they don't come down and there's a hyperkalemia which is gonna reach up to like values of 7.5 going towards 8, then I'll have to give calcium glucose insulin drip. But if like that's only a temporary thing, no, even if I decrease it back to 7 or 6 or 5, it would still rise. So especially in cases of hyperkalemia which is refractory to medical treatment, we plan dialysis. I said even if I give calcium gluconate insulin drip, it's a transient impact only, na, that calcium will antagonize the relaxant effect of potassium, insulin will send potassium inside the cells, but as long as the drug is working, once the drug effect is gone, back to square one, again you have to fight the same hyperkalemia. So if he says the word hyperkalemia refractory to medical therapy, that's when we have to go ahead with hemodialysis. In fact, that's one of the indications for hemodialysis, hyper K, non-responsive to medical treatment. As far as renal replacement therapy is concerned, I've explained to you decision making must be done by G4. And if he says what is best for the patient, the best course is allogenic kidney transplantation. For this, a cousin brother or a real brother or sister will have to come forward. We'll do a HLA matching, we'll be doing a blood group matching, and then plan a transplantation at a particular date. The point is that lots of time patients may not have a donor available, or like the relatives are not coming forward, then it's okay. I mean, we can plan hemodialysis in a patient. Hemodialysis needs to be done at least 3 times per week. Every session would be like 4 hours. So we'll discuss the complications of recurrent hemodialysis as well. And especially in children, we might be doing a peritoneal dialysis. So peritoneal dialysis cannot be done or be contraindicated, especially in patients of autosomal dominant polycystic kidney disease, because kidneys are so big that they're filling up the entire peritoneal cavity of the patient. Plus a big time risk with peritoneal dialysis can be infection, peritonitis. We need a dwell time. I mean, there are techniques available like ambulatory peritoneal dialysis or CAPD. But then the point is that this would be more suitable for pediatric age group as compared to adults, and is a slow process which will be taking like a entire day in a lot of cases where like automated systems are not available. So it will be faster to do a hemodialysis. So on a ranking basis, if I say what is best, it is transplantation, then is hemodialysis. And the last resort is if I don't have anything available, then PD peritoneal dialysis is or can be done. Now, as far as allogenic kidney transplantation is concerned, HLA matching needs to be done. The gene for HLA is chromosome 6. The gene for blood group is chromosome number 9. And we'll be doing both of these matches. But HLA matching is not mandatory for liver transplantation, heart transplantation, corneal. Here, I mean, the size matters, right? I mean, you cannot put a child's liver in an adult. You cannot put like a child's cornea in an adult. Like similarly, adult's cornea in a child. So like hair size matters. Now you can't put a child's heart in an adult and vice versa. Here it is size that matters. So this was again a question. HLA matching is not mandatory for. Then it is like HLA matching is not mandatory for liver transplantation, heart and corneal. In fact, for liver transplantation, we have very good immunosuppressive therapy. So we don't need to worry about the HLA matching component. And the donor needs to be tested. HIV because we don't want the infection to go to the recipient. And one of the infection that we need to remember is cytomegalovirus, because if it goes from the donor to the recipient, then there's a bound to be post-transplantation risk of development of graft failure. Plus, we should be doing a Doppler. Doppler should be done in the donor to rule out possibility of unilateral renal artery stenosis. See, if a person is having unilateral renal artery stenosis, on that particular side, the kidney will be smaller, and the contralateral kidney of the patient will be relatively enlarged in size. Now, suppose I am going to remove this large kidney, then he's left with that diseased kidney. Na? I mean, a guy who's having a unilateral renal artery stenosis, you can see I've shown a stenosis of the artery on one side, a substantial stenosis as compared to the contralateral side. And therefore, the affected kidney will become smaller in size and the contralateral kidney will take over the function. So we need to rule out the possibility of renal artery stenosis in the donor. As far as the recipient is concerned, we are first doing a HLA matching. That HLA matching is done for HLA-A, B, and HLA-DR. Like if this is the representation of me, and this is the representation of my brother or cousin brother, you can see that because we are coming from the same genetic tree, like I've written HLA 2 and 1 2 times because like half of genetic material comes from the father, half of genetic material comes from the mother. So I've written like 2, 1. Then you can see some numbers are matching, but they're inverted. So you can notice that me and my brother may be matching for only one, that is at HLA-A. That is for number 2 only, but not matching for the remaining one. So it's only 1 out of 6 match that is happening. You see, I'll repeat that again. HLA matching is done for, then answer is A, HLA-A, HLA-B, and HLA-DR. And then out of the 6 matches that can be happening at the moment, like if I look at this table that I mentioned before you, the match that is happening is only for like HLA-A, position number 2 and position number 2, but all other numbers are like matching in a sense that 44 and 8 are present, but they're inverted. DR is again inverted, like 4, 3 and 3, 4 respectively. So HLA matching, if it's a partial match, the chances of rejection will be more. If it's a perfect 6 out of 6 match, then the chances of rejection would be less. The only time you can be having like 6 out of 6 matches only when two eggs, single egg developing into two babies. That's like a single fertilized egg then gets cleaved into two. That's what we call as monozygotic twins. So in monozygotic twins, the DNA of the first baby will be same as the DNA of baby number 2, and therefore there would be a perfect match that would be happening. Then another aspect is we should be performing Doppler or MRA before transplantation in the recipient also, because I want to rule out iliac artery calcification due to phosphate, because if the calcification has already occurred in the recipient's iliac artery, then vascular anastomosis would not be possible on a hard calcified valve, or sutures will not hold there. Which kidney of the donor, like suppose I am the donor for my family member, then my left kidney would be removed, but where will it be produced, where will it be placed? Then it is placed in the right iliac fossa. And the advantage of placing in the right iliac fossa is that tomorrow if rejection will occur, then this kidney can be removed as well. It can be easily removed. If I place it deep down in the place of the old, if I remove the old one and place the kidney there, then chance of rejection will be more. So we place the new kidney in the right iliac fossa. And we need to perform a MRA before transplantation in the recipient also, because we want to rule out iliac artery calcification. But in the donor, we are doing scanning of the blood vessels to rule out renal artery stenosis. Both aspects have to be remembered. In the donor, it is rule out renal artery stenosis. In the recipient, it is the calcification of the artery, especially iliac artery, that needs to be evaluated. Now, if it is 1 or 2 out of 6 match happening, then what we need to do is induction therapy with anti-thymocyte globulin. If it is 3 out of 6 match, then the induction therapy would be used with basiliximab, that is the anti-CD2 molecule. But if it is 4 out of 6 or 5 out of 6 match, then no induction therapy is required. So the important thing is that maintenance therapy needs to be given in all cases on a lifelong basis, but some would be requiring a step above maintenance therapy, that is induction. Induction decision is based on the level of match. If it is only 1 or 2 out of 6 match, higher chances of rejection in spite of maintenance therapy, so we give anti-thymocyte globulin. If it is 3 out of 6 match, we give basiliximab. And as far as maintenance therapy is concerned, the mnemonic is STMA. Steroids would be given. Tacrolimus, mycophenolate and azathioprine are drugs that are used on a lifelong basis, and they have a side effect also that they'll decrease immunity. So opportunistic infections can occur in these patients also. Before I speak about these opportunistic infections, they can also ask you a pathological domain. Hyperacute rejection of the kidney, it can occur within few minutes to hours. If it is going to be acute rejection, it is going to be in the first 6 months. Chronic is after 6 months. And the number to be remembered here is 244 for the type of hypersensitivity reaction. These are the numbers according to me. If there's any discrepancy, just follow whatever the pathologist has said. But hyperacute is what they've asked. I think it was in FMG exam. Hyperacute is where the surgeon may not even get time to close the abdomen, and the organ will become cyanosed and mottled the moment the vascular supply or anastomosis is done. So this is preformed antibodies. It's not anaphylaxis, obviously. It is preformed antibodies, which would be type 2 hypersensitivity reaction for hyperacute, and chronic would be type 4 delayed. For acute, some books they're mentioning like combination of 2 and 4 present, so I can just write that also. But then the final summary is that 4 is present both in acute as well as in the chronic variety, but in the hyperacute variety it is only type 2 hypersensitivity. Now, opportunistic infections, the common ones that can occur in the first month can be MRSA, surgical site infection or herpes, or it can be like chickenpox, that is varicella zoster. But 1 to 6 months is, he can talk about 2 important infections, Girovacci and cytomegalovirus. Girovacci has been discussed last time in HIV and AIDS patients who are having CD4 count of 200, but today it's causing pneumonia. But if he says the word graft failure, there are 2 separate things. Now, one, he will say patient after kidney transplantation is having a pneumonia, and which organism is responsible? Answer is Girovacci. But if he says graft failure, then the answer would be given as cytomegalovirus. And this is again a hot favorite of, I would say, FMG examiner, that urine microscopic examination finding is always asked for graft failure caused by cytomegalovirus, where they would be in image-based question. There can be like a cell give. I'll show you the actual image also, but anyway, like they can give you an image-based question in which you will be able to see renal tubular cells. And in these renal tubular cells, like I've shown the nucleus, I've shown the cytoplasm, and then in the nucleus and in the cytoplasm, there would be like intranuclear inclusions present. And these are like intranuclear intracytoplasmic inclusions are basophilic. They are blue in color. And these are like features of cytomegalovirus infection, which would be occurring in renal tubular cells. It is causing shedding or death of these renal tubular cells. And that is why like the function of the kidney or the graft is beginning to reduce, the urine output is reducing, and the creatinine is rising. Now contrast this with the infection that is occurring after 6 months. That is lung infection to be remembered then is aspergillus. So take care if it is gonna be like first 6 months it is Girovacea, after 6 months is aspergillus. And here if he says virus, then the answer will change. Earlier it was cytomegalovirus, now it is BK virus. The virus that I'm talking about is BK virus, which is called as polyomavirus. If nothing is given in the question with respect to time frame, then single best answer is cytomegalovirus is the most common virus contributing to graft failure. As I said, basophilic inclusion bodies can be present in owl eye appearance of cytomegalovirus infection in the kidney. The most common cause of graft failure, that's what I was saying. The commonest cause of graft failure after SOT. SOT is solid organ transplantation, like kidney transplantation, or you may write the word bone marrow transplantation, that is hematopoietic stem cell transplantation, is cytomegalovirus. But if he says what is the leading cause of infection which causes post-transplantation lymphoma, then some guys casually answered this also as cytomegalovirus. The answer is not CMV then it's gonna be answered as because lymphoma now, so Epstein-Barr virus, if you are saying graft failure, then it is cytomegalovirus. Then the maintenance therapy that we are using, steroids, tacrolimus, mycophenolate, azathioprine, TMA is what I was talking about. Then these drugs on a long-term basis can contribute to development of skin cancer also. So look at the depth of questions he's asking. He's talking about post-transplantation lymphoma, post-maintenance therapy for these patients, the high incidence or development of skin cancer. And anyway, the universal one that you know from your micro and pathoglossy is that leading cause of graft failure after solid organ transplantation and bone marrow transplantation is cytomegalovirus. Who are not ready for kidney transplantation, or they don't have a donor available or finances available. Hemodialysis, we are using a filter outside the body instead of glomerulus being the filter. Now it's like a membrane outside the body, so we call it extracorporeal. In earlier times, the filter that was used or dialyzer that was used was like made up of cellulose. It used to activate complement. There used to be like allergic reactions. So now we use a biocompatible hollow fiber dialyzer, which reduces the chances of allergic reactions. The vascular access will be taken between the radial artery and the cephalic vein in our anatomical snub box. In the non-dominant hand of this person, we'll be creating a fistula where we will be connecting the radial artery to the cephalic vein. Now, why are we connecting the radial artery to the cephalic vein is because I want the radial artery blood to go via the fistula into the vein, and that will make the wall of the vein more thicker. Because see, after all, we need to cannulate this vein with a double lumen catheter through which the impure blood will come out and the clean blood would be going out. But the advantage is if you make this vein thicker due to higher pressure blood flow, then this vein can then be punctured multiple times. There would be lesser chances of thrombophlebitis. I'll repeat this again. Connecting artery to a vein will cause a development of or you can hear a bruit over this particular area by auscultation. Why are we sending arterial blood into the vein is one, because we want to reduce the chances of thrombophlebitis. We want to make this blood vessel tough. We want to thicken the wall so that it can be used for like vascular access repeatedly. Plus there would be like a pressure gradient also created. No, if you take blood from a vein, the vein will collapse. But here, because artery is connected to the vein, so there would be a pressure gradient that is created. So the rationale behind creation of this fistula, you see, either I'll require a surgeon's assistance to connect the radial artery to the cephalic vein, or we can be using a arteriovenous graft also. This arteriovenous graft would be made up of polytetrafluoroethylene. I can call it an artificial blood vessel that can be used to connect an artery to the vein. But ultimately the point is, wherever possible, when the fistula is being created, why are we creating a fistula? One is to reduce the incidence of thrombophlebitis. Second, the vein wall, because it will be exposed to high flow, it will become thicker, so it can handle repeated punctures, and then it can handle high flow rates. Plus, apart from the pressure gradient, I said total of 3 things. One is arterialization of the vein to decrease the incidence of thrombophlebitis. The vein will become thicker and stronger. We have a stronger vein, and it can handle much more large amount of blood. As far as the harvesting of fistula is concerned, it will take about 4 to 6 weeks, sometimes can take up to 8 weeks also, and we'll use a Doppler to check for whether it is now ready for the process of cannulation. The basic point is minimum to be remembered is hemodialysis is a backup thing. A hemodialysis has a side effect of itself contributing to atherosclerosis. So nowadays, instead of going ahead with the hemodialysis, we plan our patients to go in for transplantation. Those who are not having financial resources or is not willing for it, then HD would be done. And as far as principle of hemodialysis is concerned, I've already explained that in the topic of acute kidney injury, that the main principle would be answered as solute diffusion. The solutes that would be going out would be like urea, creatinine, potassium. All the bad things would be moving out. And second is water also. That is because there would be volume expansion, so ultrafiltration. Now, as far as hemodialysis is concerned, the important thing to be remembered is that across this dialyzer, the bad things, urea and creatinine and potassium, would be moving out because of diffusion process. But we are not losing proteins. No, those proteins will not be lost, or those RBCs will not be lost. So the good things in the body I'm trying to retain. The glucose is what I'm trying to retain, but the bad things is what I'm trying to lose from air. And from the dialysate side, there might even be dialysate side, what is going to be coming inside is usually bicarbonate. So what we are doing is we are trying to neutralize the acidosis component, especially like if metabolic acidosis does not respond to soda bicarbonate, then dialysis always works. How? Because you are adding bicarbonate to the system, and this entire clean blood will then be returned back to the body via the double lumen catheter. Indications for hemodialysis, I have covered in acute kidney injury. They are A, E, I, O, U. A would be for metabolic acidosis, refractory to medical therapy. So see, refractory word is written 3 times. Acidosis, refractory to therapy; electrolyte imbalance, refractory to therapy; volume overloading, refractory to therapy. So the additional things to be remembered would be renal insufficiency. In some countries like Canada, they go for planning dialysis very late, only when the eGFR goes to less than 6 ml per minute. Otherwise, usually the threshold is as at about 10 ml per minute. That's when the dialysis needs to be done in the patient, because of, I said, uremia manifestations will start even before that. But like most of the time in some countries, the threshold given is 10. In some countries, the threshold is like 6. Lower is the value, more will be the chances of complications, but then the repeated hospitalizations of the patient also need to be done. One of the absolute indications for dialysis would be uremic pericarditis, because it can deteriorate into uremic pericarditis can result in bleeding also. It can result in development of cardiac tamponade. So uremic pericarditis and encephalopathy both are given, and they ask you to select one. Then uremic pericarditis is an absolute indication for performance of dialysis. If he says what is the most common acute complication of hemodialysis, it is hypotension, already discussed in AKI. But if he says recurrent hemodialysis, then it is extracted atherosclerosis. As I explained to you, that there is an increased incidence of cardiovascular mortality even with hemodialysis. Diabetes causes increased CV mortality. CKD causes increased CV mortality, and so does hemodialysis as well. Other complications that can be seen are like dialysis dementia, where there is like A beta 2 amyloid. Alzheimer is A beta, but in this case it is A beta 2 amyloid deposition that would contribute to dialysis dementia. Then there can be carpal tunnel, again because of A beta 2 amyloid deposition. Dialysis disequilibrium is seen usually when the first time dialysis is done aggressively for up to 4 hours. Usually first time when we do dialysis, we do it for 2-3 hours only, because earlier urea creatinine were very high. Now when you are gonna cause a sudden fluctuation in the plasma osmolality, it can cause development of even seizures in a patient. So management of this dialysis disequilibrium is done with mannitol, and because you could be having loss of nutrients during dialysis, so peripheral neuropathy can occur. Let's attempt a question here. GFR less than how much is grade 3A? This was NEET PG that they asked this mathematical value, and your answer would be given as 45 to 59. This is 3A and this is 3B. That is why learning those mathematical values is recommended. Then was a 35-year-old male patient. He underwent a kidney transplantation last year with features of graft failure, and urine examination finding is shown. So he had himself mentioned that these are damaged renal tubular cells, but this no way looks like that appearance of owl-eye appearance. What I can say at the moment is, like, I can see a cell which looks like a tadpole, and then you can see a blue ring in the periphery of the cell. So this is what is technically called as decoy cells, and these decoy cells are seen with polyoma virus, that is BK virus. So the answer in this case will turn out to be option number A, and therefore what I'll do is, based on this, I'll update the note component also. Like earlier I was teaching you that the renal tubular cells I'll just hand draw this manifestation also before you. I'm showing a renal tubular cell with a slightly deranged shape. And then what I've done is that in the nucleus of this cell, I've tried to show a blue color ring present. This blue color ring is what I had mentioned as presence of decoy cell. So therefore, when you are attempting these questions, you have to be a bit careful with respect to the histopathological domain. The decoy cells are a feature that is seen with BK virus infection, which contributes to graft failure. And if it's gonna be like in the renal tubular cells, two blue spots present, the basophilic inclusions, that's what is called as a owl eye appearance. So two very classical terminologies which have been revisited. And with this, we can wind off this video. And my suggestion would be that acute kidney injury and chronic kidney disease both should be listened back to back so that you can get a better understanding of the topic. So keep hammering, guys, keep the pressure on, and keep on learning all these facts so that you become wiser and can easily break onto the other side. Thank you.